A very good evening, respected doctors. A warm welcome to all of you from the entire team USV for today's ADA 2025 live webinar, which is organized by RSSDI and with USC as a proud education partner. We are delighted to have you with us for this important session where we will explore the key highlights and clinical updates from ADA 2025 scientific sessions, which was held in Chicago. This session will cover valuable insights from well-known established therapies like sulfonylurea combination to the exciting future of diabetes management. We are truly honored to be joined by the most respected experts in the field. With that, I am pleased to begin the session by inviting our moderator, Dr. Sanjay Agarwal, sir, to take us forward. With this, it's pleasure to introduce Dr. Sanjay Agarwal, sir. Dr. Sanjay Agarwal, sir, is a honorary secretary governing council of National RSSDI. So he's also a member of editorial board for BMJ, Open Diabetes Research and Care Journal, associate editor of International Journal of Diabetes for Developing Countries. And sir is also having a wide research experience, member of writing committee for RSSDI in various guidelines. And sir is also an author of book Clinical Atlas in Diabetes as well. So he's also a chief editor of RSSDI, Insulin Monograph, actively involved as a principal investigator in various landmark international research trials. So he's also a faculty at various national and international meetings and mentor for the many postgraduate program as well. With this, I would like to hand over session to Dr. Sanjay Agarwal, sir. So over to you.
Thank you very much, Amit. And it's a pleasure to be part of this meeting. Many of us have traveled to the ADA 2025, and in a way, this meeting was different because a lot of new things were discussed during the ADA 2025, and we thought that it would be nice to bring the new concepts, new thoughts, that were discussed. A lot of talks revolved around obesity, new molecules, new research trials. And I think it's just the right time post ADA that we should bring these thoughts together. So we have some of the greatest speakers that have looked at all this and dissected it out for you. And we want to bring this in a nutshell so that you have key take-home messages about what was discussed during the ADA. To begin with, I'm going to invite Dr. Bansi Sabu to sort of give his overall assessment of what was discussed during the ADA, because he was very actively involved during the meeting. In fact, he had a couple of presentations and he was involved in some of the committees. So I'm sure nobody better than Dr. Bansi to bring you a concise view before we take it up with individual speakers on specific topics that were highlighted during the ADA. Dr. Bansi Sabu really needs no introduction. I think he's a wonderful person. He's been the past president of RSSDI. He's the current chair of the Southeast Asia IDF. He's done numerous research publications to his credit. He has been part of many organizations, and I think we are really privileged and honored to have with us. I think if I read his CV, the entire evening will go away. So I'm going to, just hand this over to Batsi. And Batsi, over to you. Let's hear from you the overall highlights of ADA. Thank you very
Sanjay,
much.
first of all, thanks for this wonderful words of introduction for me. And I'm thanking RSSDI and thanking you particularly for bringing ADA highlights immediately after American Diabetes Association. So once again, thanks Sanjay for your dynamic as a secretary, as well as your multiple activities which you are doing. We are very happy today that we have our current president, past president, president-elect, even Dr. S.V. Madhu and Dr. Shashank Joshi today for our meeting. This time ADA was, I think, completely different. A lot of science was discussed and things are really moving. Now we are changing our gates from, we started with long back, it is 85th meeting of American Diabetic Association. It was started like with UKPDS when we were all trying to achieve a tight glycemic control, when you just wanted tighter glucose control, which will have less and less complication. Over a period of time, we understood that it's not just tight glycemic control, it is how longer the diabetes and what are the risk factors they have, and that, something like steno paper had come, and then how to treat diabetes that had come, and then CV outcome data has completely changed the way we are treating diabetes. So if I see my practice, what I used to write in 2000 and what I used to write in 2010 and what I used to write in 2020, my prescription is completely changed. But in last 5 years, what we understood, it's not just the sugar control. It's not just the complication preventive approach by giving them a newer medication, but it has also revolved around obesity management. It has evolved around managing fatty liver. That's a liver had also become an important organ. Like we used to understand it's only heart or kidney, which is in a major organ, but it is the fat cells, it is the obesity, it is the liver fat, which had become very, very important. And this had increased our, interest in GLP-1. It's not a new molecule. We know that GLP-1 had come in India also. We had used, even it was a twice in a day exenatide, and then twice in a, and then it has come with a once in a week, every day. It had shown that there is a good significant amount of weight loss has been seen in patients while we were using it, GLP-1. And then GLP-1 had come with a weight loss agent, and then it had shown a molecule which is decreasing the weight like 15-20%. And then the molecule had come with not single agent, dual GLP. But this time, very interesting data which we had seen even in phase 2 trial. Last year also, triple agonist had come, which all other my colleagues will agree. But this time, first time I had seen even the quadruple combination. They are thinking of not only GLP-1, GIP, they were thinking of even calcitonin and amylin agonist to be combined or maybe given in a single injection, which we never thought that these are the also the molecules which can help our patient to reduce the weight. Now, we already have a molecules which can significantly reduce the weight. But the problem is these weight loss agents or weight loss agents which are like GLP-1 and GIP combination, they decrease weight, but they simultaneously also decrease the muscle mass. And that has become a challenge. It's a sarcopenia has also become a very challenging. And at the same time, they were not reducing the weight only from the liver part. That was also very interesting. So the molecules like Kegrisima, I'm not here to talk about any company, but that molecule had come, which is decreasing more of a fat from the liver fat. That was very interesting. And then the newer molecule, which is like triple agonist and quadruple, it was not for further decrease in weight because already existing molecules were reducing weight by 15 and 20%, but they are thinking of not just weight reducing agent, but at the same time muscle preserving. It means they will not decrease the muscle mass. They will primarily decrease only the visceral fat. And that is what we are looking for. So probably after 5 years, again, as I told you, in 2000, in 2010, in 2020, in 25, how we will be writing to our patients. And again, I think down the line in 2030 and 35, our prescription will completely change the way we are treating our diabetic patients. It had also shown some of the data that it is the weight which is very important. For how long you have the weight. Suppose somebody at the age of 30, he have the higher weight or the higher the BMI, he found to have more cardiovascular disease over a period of time in 10 years, 20 years in person in compared to the person whose visceral mass is not, visceral fat is not very high. So these are some of the data which were very important. This time, one more interesting thing which I had seen in exhibition area. If you will find a lot of these molecules which were either in already in market, in existing market, but very less talk or less in exhibition about the insulin or even the existing anti-diabetic molecules. What we had seen is technology. More of a exhibitions where the newer and newer technology were there. We had seen also the resmetirom, which is also going to be there in India very soon because some of the companies have already introduced, and I think it is patented or off-patented, no idea in India, but that was a molecule which is for liver fibrosis with already an advanced stage of NFLD can be used in our patients. We had also seen the molecules like teplizumab, which is a preventive type 1 diabetes. That's a molecule which is going to be there in India also. And that was also one of the very interesting highlight this time. And probably that molecule will also come. And we were very happy that Dr. Amit Gupta from our RSNGN Executive Committee member, he was part of a talk which was a symposium on a prevention. And he had talked about every aspect of diabetes prevention, which he had shown, tried to show the data from Indian diabetes prevention program to even the international diabetic prevention program, multiple program which he had shown. But in future, I think this obesity prevention itself will decrease the incidence of diabetes. It will prevent diabetes, and they will become the molecule of diabetes treatment, diabetes prevention, obesity management. But at the same time, I was very happy to listen some of the molecules which were like older molecules, and we always feel that was a symposia for Goldie, all oral hypoglycemic agent, and they had talked about the sulfonyl. They talked about the molecules which was in EDA or in their guidelines. They had pushed it very far away, but still there were talk related to that, and it is still very important to manage glucose level. It's not just the preventive complication prevention approach, because at the same time a person coming to you is for diabetes control. So I think our approach should be like that we should treat the diabetes for their complication to be prevented, and at the same time we should use the molecule which will also control the sugar. Definitely a safe and a smart use of sulfonyl is very important, because it can lead to hypoglycemia. So there were a lot of talks related to how we can prevent hypoglycemia. It was not in type 1, in pregnancy, in type 2, and continuous glucose monitoring was really a revolutionary uh, monitoring device. Multiple companies are there. In India also there are companies, and I'm sure in India we will bring a lot of new technology which will be continuously monitoring our patients, and we will also able to reduce our risk of hypoglycemia, at the same time a tighter glycemic. Unluckily, in India, average two-thirds of our diabetic patients are still not achieving a good control of diabetes. And I always say that in last 25 or 27 years of my diabetes practice, even so many newer molecules have come, so many conferences I have attended and I have organized also. I mean, highest number of CMEs in last 20-25 years, so many online programs, but still the average A1C is not. So somewhere down the line, I can see that still it is not reaching to the masses. It is still remain in the class. So very important this year, in a guideline, they had kept in American Diabetic Association meeting a symposia only on guideline. And what was the highlight? The guidelines we are making since years, but it is not actually reaching to the primary care physician. It means it is not accepted, or you can say it is accepted as a booklet, as a paper, but in clinical practice, actually we are not utilizing. I mean, the primary care physician of US, and same situation is in India, because there are 100,000 physicians in India. RSSDI guideline with the help of USV only. Actually, we reached out to all our district coordinators, all our taluka representative in rural area, also case-based RSSDI guideline, we try to teach them. But still, what I am finding is that two-thirds of diabetic patients are not getting good control. So thanking USV, thanking RSSDI for reaching out to all the physicians across the country, even in the rural most area, and trying to teach them best of ADA, what we could get from the best of the speakers today we have. And we will see that in future, they should use these guidelines more in their clinical practice when they are writing prescription, and make sure that their patient sugars are getting control and they don't get complications. With these few words, once again, thank you, Sanjay, for giving me an opportunity, and giving me opportunity right time, because 8 to 8:30 I am finishing it. And I will be joining later on once again in discussion. In between, I have to finish one more talk. Thank you, Sanjay, once again, and thank you, USP and Dr. Amit from USP for giving me this wonderful opportunity. Thank you.
Thank you.
And
Thank you
I can
so.
introduce, the first speaker, because he is very close to me, President-elect, Dr. Anuj Mehsri. Uh, he is having multiple publications. His work in hypertension and pregnancy and diabetes, these two works internationally known. He is currently president of Asian Pacific Society of Hypertension, and he has done a lot of work in field of diabetes and pregnancy. With this, now I hand over to Sanjay for further proceedings. Thank you.
Thank you so much, Bansi. It's really a pleasure and honor to have you with us. It's been a great enlightening talk and a very concise overview of what you really gave. I'm really privileged to have with us, and Bansi, I'll request you to join back for Q&A I'll have somebody call you up once we start the Q&A. So I'll let you know about it.
Right. I will be joining at 9 o'clock, definitely.
So this is really a proud privilege to introduce President-elect Dr. Anuj Maheshwari. And we also, he has been part of the ADA program. He had presentations out there and he gives some incredible amount of data. He had posters also during the ADA. Dr. Anuj needs no introduction. I think he's done incredible amount of work through the ACP, through the International Society of Hypertension, and he's got numerous publications to his credit. Today, Dr. Anuj Maheshwari is going to talk to us about brief overview of ADA 2025 and session objectives. I think he will really do justice to this topic. So over to you, Dr. Anuj Maheshwari. Anuj, you're muted.
Anuj, you are muted. You share the slide. And
thank you, Dr. Sanjay, and thank you, Dr. Bansi, for kind introduction, saying good words for me. I am really overwhelmed. Sharing my slide set. So today's I shall be talking about the brief overview of the ADA 2025 and its sessions, what we were there. So these brief overviews would be for the different sessions which has been done. Details would be given by the subsequent speakers. I shall be talking about the important and themes and specifically what the message we could get from those sessions. So I shall be talking about lot of talk has been done this time in the ADA about the semaglutide. We had the STRIDE trials. And then more importantly, we could see the orforglipron, an oral small molecule GLP-1 receptor agonist in early type 2 diabetes. It could be having its role. Treatment of the hypercortisolism in people with difficult to control type 2 diabetes has remained the talk of the ADA this time, and final results of the catalyst trials could come out there. Effects of the dorzagliatin, insulin glargine, and metformin on nocturnal endogenous glucose production in type 2 diabetes. And very interestingly, we could find all the three molecules very equally doing good. A 4-week treatment with dapagliflozin reduces the insulin-stimulated renal glucose uptake. Then we had a talk on the glucose-lowering drugs with focus on the primary prevention of the cardiovascular disease, what actually matters for all of us, and upfront lower dose statin plus ezetimibe for managing hyperlipidemia, because no glucose control is complete without managing dyslipidemia. So dyslipidemia is very important part of the overall diabetes management if we look for the prevention of the cardiovascular adverse outcomes. So coming over to the first part of the agenda, semaglutide increases walking capacity in patients with peripheral artery disease and type 2 diabetes. We were all knowing about the good things and its qualities of these molecules as far as the glucose lowering is concerned, as far as weight loss is concerned, as far as the cardiovascular risk prevention is concerned. But very nicely, we could come out in this STRIDE trial that it is very good for those patients, those who are having the peripheral artery disease. The STRIDE trial in the phase 3 multinational double-blind randomized clinical trial conducted at 112 outpatient clinical trial sites in 20 countries, 792 adults more than 18 years with type 2 diabetes. Those who are having a peripheral artery disease with intermittent claudication have been included, having the median age 68 years, 25% of them were female and rest were male. And this study has been randomized between the semaglutide and placebo for 52 weeks. Outcomes were interestingly reduced ankle brachial or toe brachial index indicating impaired leg blood flow. Persistence of the efficacy after treatment cessation, maximum walking distance could be found to be improved in the week 57, the users of the semaglutide. Semaglutide demonstrated an improvement in maximum walking distance compared with the placebo 5 weeks after the treatment cessation. So primary outcomes of this study were the semaglutide significantly improved walking distance, enhanced quality of life, and reduced disease progression by 54%, well tolerated, low rate of the serious adverse event, consistent with known safety profile, and subgroup insights were there were the benefits observed regardless of the baseline A1C, diabetes duration or treatment intensity. Efficacy consistent across all BMI categories, independent of the SGLT2 inhibitor use or not to be used. Semaglutide is the first therapy to reduce the major adverse cardiovascular events, improve cardiometabolic and kidney outcomes, and improve walking capacity, related quality of life, and disease progression in patients with peripheral arterial disease and type 2 diabetes in 25 years. Now come over to the next one, that is the orforglipron, an oral small molecule GLP-1 receptor agonist, and it has been tested for the early type 2 diabetes. So what we could see here as a result of this study, this was to evaluate the efficacy and safety of this molecule, which is a non-peptide GLP-1 receptor agonist. How can it really help us if the type 2 diabetes in its incipient state, and how can it really helps us in weight management? This was a randomized double-blind placebo trial. 559 adults with early type 2 diabetes, they were kept on the diet, exercise only. HbA1c was ranging between 7 to 9.5. BMI was more than 23. And they have been randomized between the two groups, recipient of the orforglipron 3 milligram, 12 milligram, 36 milligram, or placebo once daily for 40 weeks. Primary outcome was change in HbA1c from baseline to week 40, and secondary outcome, which was observed, the percentage change in the body weight from baseline to week 40. The mean baseline HbA1c 8% was there. Orforglipron significantly reduced HbA1c and body weight in adults with early type 2 diabetes over 40 weeks with a favorable safety profile. Most common adverse events, what we could observe, it are mild to moderate GI events, mainly during the dose escalation. We could not find any severe hypoglycemia, and discontinuation due to adverse event was 4.4 to 7.8% in the treatment group as compared to the 1.4% in the placebo group. Let's come over to the most talked and most exciting session of the ADA this year, treatment of the hypercortisolism in people with difficult to control type 2 diabetes. We could see the catalyst trial. In fact, this is the problem what we really look little less in our Indian population, where we are going to treat the diabetes. And many a times we do not find the good control of the diabetes. We rarely look towards this cortisol secretion, because in India, a lot of people are living with the sympathetic overdrive. A lot of people are having their excessive hurry in their day-to-day schedule, and hypercortisolism could be there if we can really go for the testing of that. In this study, we were having a background of 50% of type 2 diabetes patients who were failed to meet HbA1c target despite multiple medication and lifestyle changes. We are full of these kinds of the examples in our Indian population. Hypercortisolism means excess cortisol production, can raise blood glucose, and may underlie treatment resistance in some patients. 1 in 4 patients with difficult to control type 2 diabetes may have undiagnosed hypercortisolism. The Catalyst study explored whether hypercortisolism is a contributing factor in people with difficult to achieve HbA1c targets despite multiple medications. There was a randomized double-blind placebo-controlled trial, 136 patients with hypercortisolism and uncontrolled type 2 diabetes, those who were treated with mifepristone or placebo for 24 weeks. So mifepristone is effective in improving glycemic control, weight, and abdominal obesity in patients with type 2 diabetes and hypercortisolism. This was the conclusion of this study. Expanded screening for the hypercortisolism in patients with difficult to treat type 2 diabetes actually helped us in exploring of the cortisol-directed therapies as adjunct treatment. Assess impact in the less advanced type 2 diabetes, compare other cortisol-targeting agents, and next step would be to evaluate long-term effect on the diabetes complications and outcome of this. We could see 10 pounds of the weight loss. We could see 2 inches or more than 2 inches of waist circumference reduction. At the same time, we could see the reduction in the dose of the insulin, reductions in the other diabetes medication, and we obviously this was all with the benefits of the HbA1c reduction more than 1.5% with mifepristone. Another session was there in which effects of the dorzagliatin, insulin glargine, and metformin was seen on the nocturnal endogenous glucose production in type 2 diabetes. Nocturnal endogenous glucose production in type 2 diabetes is seen to be elevated due to increased glycogenolysis and more of the gluconeogenesis. The study evaluated whether dorzagliatin, insulin glargine, and metformin reduced the endogenous glucose production by targeting glycogenolysis and gluconeogenesis. 23 type 2 diabetes adults have been participating in this study, having BMI 32, HbA1c around 7, and diabetes duration around 9 years. This is a 6-week monotherapy intervention with these three drugs. And interestingly, the outcome what we could see that endogenous glucose production, glycogenolysis, and gluconeogenesis measured at 1, 4, and 7 a.m. using glucose and 2-HTO methodology. This is the specific tagged glucose and its methodology to be found out. And dorzagliatin, insulin glargine, and metformin, these three groups were there. Both dorzagliatin and insulin glargine effectively reduce nocturnal glucose, endogenous glucose production, mainly by lowering glycogenolysis. Metformin alone did not sufficiently suppress this endogenous glucose production overnight, but the combination therapy targeting both glycogenolysis and gluconeogenesis may optimize nocturnal glycemic control in type 2 diabetes. So what we could see that all the three medications were showing good effect on the significant reduction at all time of the endogenous glucose production. Dorzagliatin and insulin glargine has also found a consistent drop across time point. But metformin was not having very good effect on the this endogenous glucose production reduction in the night time, but it was definitely worked as a complementary therapy with the inadequate reduction, although there, but increased, we could observe that we could find that the end of the therapy with the combination. A 4-week treatment with dapagliflozin reduces insulin-stimulated renal glucose uptake. Final outcome was the FDG PET scan were conducted pre and post treatment using hyperinsulinemic euglycemic clamp, and 4-year follow-up assessed change in the eGFR. And in this study, these were the two parts of the study. One was of the 4 weeks and another was the 4 years. What we could get, the short-term study, which was of the 4 weeks, we could see decreased renal glucose uptake in dapagliflozin arm, trend towards lowering of this, and mean value of the glucose uptake suggests reduced glucose uptake during the insulin stimulation. In the long-term part of this trial, which was of the 4 years expanded, stable kidney function in SGLT2 inhibitor group. In this, eGFR ranged between 81.4 and reduced to the 76.2 indicates preserved renal function. Dapagliflozin reduces renal glucose uptake in the short term, potentially reflecting in lower tubular energy demand. This effect, alongside a stable eGFR over 4 years, supports the role of the SGLT2 inhibitor in renal protection in type 2 diabetes. Further studies may be giving more clarity, and we should find a mechanism of the underlying reduced renal FDG uptake. So, on the basis of this, ADA 2025 has modified its algorithm chart of the glucose lowering medication in management of the type 2 diabetes. No doubt the healthy lifestyle, behavior, diabetes, self-management, education, and support remains on the top for the management. But once we have to start the pharmacotherapy, it is to be decided what is our goal. If our goal is the cardiovascular and kidney risk reduction in high-risk individuals with type 2 diabetes, and we are looking for the atherosclerotic cardiovascular disease, the option should be coming from the GLP-1 receptor agonist or the SGLT2 inhibitor. But once we are looking for the heart failure patient, SGLT2 inhibitors could be the choice of the therapy. More of the CKD, then we should look for the SGLT2 inhibitor with primary evidence of reducing CKD progression already are there. And GLP-1 receptor agonist could be the another choice if in case the SGLT2 inhibitor is not working or we need to add on some therapy to the SGLT2 inhibitor for the glycemic correction, then GLP-1 receptor agonist with proven CKD benefits could be the choice. If A1C is above goal for individuals on SGLT2 inhibitor, consider incorporating a GLP-1 receptor agonist or vice versa. On the other hand, if we are looking for the goal achievement and maintenance for the weight and glycemic goals, then achievement and maintenance for the glycemic goals, metformin is the right choice to start with. On the other hand, if we are looking for the weight management, obviously the therapies which are more focused towards the weight management, that could be GLP-1 receptor agonist, that could be for the SGLT2 inhibitor together with the metformin can always be the choice. If A1C is above goal or significant hyperglycemia or hypoglycemia or barriers to care are identified, then we can really look for the addition of the therapies like GLP-1 receptor agonists, like dulaglutide, like oral combination with the injectables with GLP-1 receptor agonist and insulin together. Followed by that, if still we need to something and GLP-1 receptor agonist is not acceptable, DPP-4 inhibitors could be used as a choice for the next. The glucose-lowering drugs which has demonstrated to reduce the cardiovascular events largely were mainly dapagliflozin and dulaglutide. GLP-1 receptor agonist, SGLT2 inhibitor effects on the major adverse cardiovascular event stratified by the atherosclerotic cardiovascular disease were seen that in established atherosclerotic cardiovascular disease, there were no doubt both the drugs were absolutely good. But once the patients were having the multiple risk factors, these were doing its best, but SGLT2 inhibitor were found little on the advantageous side as compared to the GLP-1 receptor agonist. So it was a CV outcome study with glargine U100 as compared to the glimepiride, liraglutide, and sitagliptin in type 2 diabetes. Great study compared cardiovascular CV outcomes in type 2 diabetes patients treated with glargine U100, glimepiride, liraglutide, or sitagliptin. There was no significant difference in the cumulative incidence of the major adverse cardiovascular events among the 4 treatment groups. Liraglutide showed a trend towards the lower risk of the composite CV outcome compared to the other 3 treatments, with a statistically significant reduction for broader endpoint, MACE-5 and MACE-6, and hospitalization for the heart failure. Overall event rates were low, 241 MACE-3 events, 4.1%, and 407 MACE-6 events during that study. The conclusion of this was dulaglutide and dapagliflozin are approved for the primary prevention. Meta-analysis show that SGLT2 inhibitors lower the risk of hospitalization for heart failure and adverse kidney outcome in type 2 diabetes, regardless of the cardiovascular disease, but do not lower major adverse cardiovascular events risk in high-risk group. The latest SOUL meta-analysis found that GLP-1 receptor agonists reduce major adverse cardiovascular events risk regardless of the cardiovascular disease status within trial population. Means it is equally effective in the high risk groups, in the groups which are having the higher risk factors, but risk exactly is not that much high. In both the groups, it is equally effective. In the GREAT study, liraglutide lowered the risk of the major adverse cardiovascular event plus heart failure compared to insulin, SGLT2 inhibitors and DPP4 inhibitors in a lower risk group. So now the talk cannot be completed if we do not talk about the dyslipidemia. Upfront lower dose of statin combined with the ezetimibe for management of the hyperlipidemia. Stepwise approach have been more recommended, and it was found to be useful in as a result of various studies. In America as well as in Europe, this approach is not very well appreciated as of now. The stepwise strategy does not work in Europe. Lipid lowering therapy is not optimized during follow-up despite clinical guidelines. In the US also, the stepwise strategy does not work in, and suboptimal prescriptions are rarely corrected post-discharge. So this is the problem even with India also. We start the statin therapy and never try to up titrate or down titrate that as per the requirement. So it is recommendation that we should look for the treatment, lipid lowering treatment in the light of progression of dyslipidemia or correction of the dyslipidemia. Limitation of the stepwise approach in high and very high cardiovascular risk patient could be observed at the poorly implemented, leading to undertreatment of a large number of the high risk patients, and many of us fail to achieve target LDL-C correction, leaving them exposed to residual cardiovascular risk. It has got the benefits of the moderate dose statin when it's combined with the ezetimibe combination. It achieves 60 to 65% LDL cholesterol correction, comparable to the better than high intensity statin monotherapy, well tolerated with a lower incidence of the statin associated muscle symptoms, offers greater reduction in cardiovascular events than high intensity statins alone, especially post acute coronary syndrome. Improved adherence when provided as a fixed dose combination, fulfills the needs for the early intensive and sustained LDL cholesterol lowering in post acute coronary syndrome patient. Additional advantage in patient with diabetes is their ezetimibe improves postprandial lipemia, contributing to further cardiovascular event risk reduction. Thank you very much for your kind listening.
Thank you, Anuj. I think the lecture was wonderful, extremely informative, and an overview of all the important trials and discussions that happened during the ADA. Nobody better than you who could have given this lecture. I think truly a master oration given by you. It speaks of experience that you've done in the field of hypertension and diabetes, obesity. And just this overview gives a lot of thoughts to people who are listening to the lecture. So thank you very much, and I'll request you to be back for the Q&A at the end of the session. Maybe we'll have a couple of questions for you. So we'll let you know once the Q&A starts, so we can join in just briefly for the Q&A at that point of time. It gives me a great pleasure to introduce to you Dr. S.V. Madhu. Dr. S.V. Madhu has been the past president of the RSFDI. He's been also the past president of DIPSI. He's been the past president of the Endocrine Society of India. He's been the editor-chief of IGDDC. He's going to talk to us today on a very important subject. We've always talked about the older drugs. And, we don't know what the status of the older drugs have been. During the course of ADA, there has been a discussion on golden oldies, and nobody better than S.V. Madhu seen the actual transition of treatment happen over a decade, and I mean, over 4 decades, I would say, or 5 decades that he's been in practice, to see all the older molecules transitioning into newer molecules and what is the status of the older molecules. So thank you, Dr. Madhu. And I also welcome, Dr. Vijay Vishwanathan and Dr. Rakesh Sahai, our president and immediate past president, who are present at the meeting. So, Dr. Madhu, over to you.
Thank you, Sanjay. And let me just share my slides. Yeah. Are my slides now visible?
Yes, sir.
Okay. Okay, I think thanks to Dr. Sanjay and all of you and the USV for inviting me. And I think one of the reasons I felt that I've been included is for including an oldie like me is to remind everybody that the golden oldies of sulfonylureas, metformin, and pioglitazone probably still around amongst all the new and vibrant young diabetologists in this panel, just like the newer, vibrant, dynamic drugs which are coming each day and taking management of diabetes forward. But we need not forget some of the older drugs which still have a place and status, of which I'm going to discuss in the next 10 to 15 minutes. Slides don't seem to be moving. Let me check. Okay. What I'll basically be doing is, start with the 2025 ADA standards of care, which has been alluded to in detail by Dr. Anuj, but we'll focus on the older drugs and what their place could be. And we'll talk a little bit in detail about metformin and whether it's a primary approach after lifestyle. When is metformin the preferred choice, and what are the co-benefits and non-glycemic benefits of metformin? Sulfonylurea, the benefits, adverse effects, we all know, but we'll recapitulate that and then come to when is sulfonylurea perhaps a preferred treatment or what is the role in today's scenario. Pioglitazone, again, which has been unpopular for several reasons, however, has several beneficial effects. We'll talk about its effects on glycemic control, effects on cardiovascular outcomes, how it is so crucial in the management of MASH, and the profound effects on diabetes prevention, and therefore, despite the safety concerns, it still has a role. So this will be broad outline of what we will be talking. So this slide we've just seen before 10 minutes ago, but what I'd like all of you to focus is only on this limb. Whenever our target is not focused on a specific issue like an overriding concern about cardiovascular or kidney disease, an overriding concern about weight management, then we have to stick to this, which is broadly the case with most diabetic patients that we come across. And these patients who do not have these additional concerns, the main concern would be to achieve and maintain good glycemic control, treat them to target, and prevent the microvascular complications, as we all know and as we've been hearing over the years. And in this limb, or to this effect, or to this goal, I think the efficacy of glucose lowering is one of the important things. And as you can see, the three agents are listed in this box, showing that they're highly effective. Unless you require very high uh, efficacy, that means a very severe hyperglycemia, where perhaps you have to depend on insulin or maybe some of the GLP-1 analogs. In all other situations, wherever efficacy of glycemic control is an issue, all these three drugs, the metformin, sulfonylureas, and pioglitazone, probably fit the bill. And that's what we're going to discuss in the next slides. First, let us talk about metformin. It's been touted as for several years as a primary approach after lifestyle, and this is changing in the rapidly evolving scenario. And some people are talking about, as we've seen from the chart ADA recommendation itself, if your concerns are predominantly renal, cardiac, or significant weight loss is the goal or main target, then metformin may or may not be the primary approach, but in all other cases, it remains the primary approach. And whenever you decide to give metformin, the initial pharmacotherapy after 3 months, if glycemic controls are not achieved on lifestyle, then you start with, let's say, immediate release 500 milligrams or 850 milligrams pre-breakfast, and then gradually titrate over 4 to 14 days to a BID or a TID schedule until you achieve your target or you reach 2 grams of metformin a day, as we're all aware. And you could have some side effects, as we all know, and therefore it's better taken with the meal. Of course, if you convert it later to an extended release, that helps the GI side effect profile. And you monitor, as we again are aware, long-term with liver function, kidney function, which we would do even at the start, because if the eGFR is less than 45, you may not start. And if it becomes less than 30, you may even discontinue. And you check the renal at least yearly, or even sooner if required. And of course, contraindications are well known: hepatic disease, heart failure, serious CVD, lung or hypoxic conditions, all of which may predispose to lactic acidosis and other side effects. And you temporarily discontinue when IV contrast is to be given. And normally, especially if there is anemia, you would like to monitor vitamin B12 levels and see if they're in order. So when do we recommend metformin? For hyperglycemia treatment in children over 10 years of age, broadly, this would be the drug of choice or the primary drug. But this is the main concern, the hyperglycemia itself. In the elderly, of course, it's still recommended, but with regular renal assessment. In pregnancy, it's not the drug of choice, although it is a part of the recommendations. Insulin remains the cornerstone, but yes, in some patients, even in the national guidelines, metformin is given as one of the drugs to treat whether it's a pre-existing diabetes, but more often for GDM as one of the options. But insulin in general, ADA-wise, probably is the preferred drug. Prevention of other comorbid chronic conditions, microvascular, if you control the glycemia, all the microvascular complications are prevented, so therefore it is useful. Even there is a specific effects to benefit cardiovascular disease and cardiovascular outcomes with metformin, and therefore, even to that effect, metformin can have a role. When is metformin the preferred choice? Stronger evidence of efficacy is seen in type 2 diabetes mellitus, initial treatment or following lifestyle changes, and as I said, when hyperglycemia is the main goal of management. It could also be seen in pre-diabetes, and it could also be seen in situations where there is a history of GDM, and in the post-GDM phase, you want to prevent or postpone the onset of diabetes. These are the three situations probably where metformin could be the preferred choice, and it could even be preferred in pre-diabetes management. That's one of the most important pharmacological agents which been uniformly recommended even through large clinical trials for prevention of diabetes or prevention of conversion of pre-diabetes to diabetes. Younger patients, particularly obese, overweight individuals, as an adjunct to lifestyle sometimes, where cost is a factor, history of GDM in particular, and of course, it helps prevent other complications as well. This is a study actually which showed very clearly that at least in scenarios with history of GTM, the prevention of diabetes is far more significant, as you can see from this chart here itself, much away from the placebo as compared to those without GTM. So in a scenario with a history of GTM, perhaps metformin is a much greater role in prevention of type 2 DM in that scene. It also has co-benefits in terms of all these trials where you can see its specific effects on CVD and stroke prevention. It could also be used, as you can see, in polycystic ovarian syndrome, even without diabetes. But its role in pregnancy, we have discussed in diabetes, and its role in reproductive health, although there are some studies which are showing some effects, it's still not very clear, and remains to be defined. Coming to sulfonylureas, there are 9 trials where, compared to placebo, this drug has been shown to be very effective. That means a HbA1c reduction of 1.5%. And in combination with other treatment, 1.6%, 4 trials. When added to insulin, 17 trials, showing at least a 0.5% additional reduction of A1C. Therefore, of course, you don't require very high doses, and we all know that above 50% of the peak dose, the benefits are not much more, the side effects are much more. This is a meta-analysis which shows that the concern about cardiovascular safety with sulfonylureas is only a myth. And as you can see, the odds ratios of all these outcomes are very close or in or around 1, and therefore not significant. We are only concerned with glimepiride. As far as the important thing to note is the metabolite is weakly active, and therefore that's a plus and advantage, as we will see in terms of hypoglycemia. This, of course, one of the major concerns with sulfonylurea, and therefore, wherever hypoglycemia is of concern, you probably will be wise to choose other drugs. Relative risk of serious hypoglycemia with oral is, as you can see, as you move up with glimepiride, there's almost a 3.28 fold increased risk of hypoglycemia. Although severe hypoglycemia is only 0.8%, mild hypoglycemia is about 10% and is a real risk. This can be, related to several factors. The longer acting ones, much more important, active versus inactive metabolites. We said glimepiride has only inactive metabolites, and therefore the risk would be to that extent lesser. Higher versus lower dose, the lower dose will not have that risk. And of course, the interacting antimicrobials, we all know, the patient which we commonly give to a diabetic individual can predispose to sulfonylurea-induced hypoglycemia, and we should be aware of this. The benefits, high efficacy, we've seen that. Improved glycemia, reduced microvascular and macrovascular complications proved through various long-term studies. Reduced all-cause mortality, low treatment burden, inexpensive, because with a single drug you can achieve significant control, and it's inexpensive. So it does have a clear-cut place even today in the glycemic management of individuals where this is the primary concern. Side effects we've discussed. So in conclusion, it is effective and safe, but it doesn't have off-target benefits or non-glycemic benefits, so to speak, in terms of cardiovascular disease, CHF, kidney or liver disease, and therefore, whenever those are the primary concerns, you will choose other drugs. So when there is no CVD, CKD or liver disease, in younger patients, adequate nutrition, no cognitive impairment, low hypoglycemia risk, you can choose sulfonylureas. If you don't achieve glycemic targets with metformin, when that is the main goal, you add sulfonylureas. So these are the places I think where sulfonylurea is still preferred, and we use it all the time in our practice, my practice being in a government setup. What about pioglitazone, the third drug in this old golden oldie section? As a monotherapy, lowers HbA1c by 1%, so fairly good, effective. The most important thing about pioglitazone is that glycemic control is durable. It lasts over years. One of the most important agents where once you achieve the A1C reduction, it does not wane off very soon like other drugs like sulfonylureas and many other drugs, as you can see on the right, where with pioglitazone, this doesn't happen. That's one of the major benefits. This is what, although it's been known for several years, it's not talked about so much. We've talked much more about bladder cancer. We don't talk much about the CV outcome benefits. As you can see almost uniformly, whether it's a surrogate marker, the CIMT, or the hard outcomes, which are listed on the right side, there is significant reduction. The stroke reduction is to the extent of 47%. 28% reduction in FMI. So these are not small risk reductions, and therefore pioglitazone is, to my mind, is an underutilized drug. The only thing we need to do is utilize it appropriately, where it is of low risk, and get the maximum benefit out of the agent. Don't stop using this drug. Pioglitazone exposure and cardiovascular, again, you can see even here, those who were exposed to pioglitazone versus those who were not exposed, you can see the mortality rate significantly better. Decrease in cardiovascular events, incident stroke, MI, insulin resistance, mortality, what have you, all the endpoints. And to add to all this, the beneficial effects of pioglitazone on MASL, MASH, improves liver enzymes, improves inflammation, reduces fat, reduces fibrosis score. So at all stages, this has a role. Prevention studies, just focus only on the act now because we are talking only of pioglitazone. 72% decrease in incidence of diabetes mellitus. No other drug has achieved this much benefit compared to placebo. Safety concerns, of course, do exist. We need to keep this in mind. The ones are listed quite clearly here. Congestive heart failure, weight gain, the bladder cancer story is also there. Bone fractures, of course, particularly in women. And this study, of course, in long term of more than 13 years showed hazard ratios only 1. But it's always good to keep in mind that this could happen. Avoid it in high-risk individuals, older patients, smokers, those who have hematuria and the like. And if you do that, for most cases, it is safe. Do not prescribe it patients with CHF, to postmenopausal women with osteoporosis, and use lower doses, maybe 15 or maximum 30 instead of 45. If you keep these things in mind, I think it's a very good drug to use even today. One additional thing which has come up from some of the recent studies with GLP-1 analogs, when you combine TZs, especially pioglitazone with GLP-1 analogs, there is further reduction, as you can see this, the lowest green line, which shows a clear additional benefit. So therefore, why not? And to some extent, even counter the weight gain. And so this could be a useful combination, combining GLP-1 with these areas, particularly pioglitazone. Although there are several novel agents, I think still pioglitazone, approved in 1999, continues to be the most important agent in this group. May be considered as first-line agent in those without evidence of heart failure, may be used in combination with GLP-1 and even SGLT2 inhibitors, particularly in those with MASH and high triglycerides, and lower dose can be used to reduce side effects. So I think that's the summary of the story. The three important drugs, the responsibility of which was given to me to talk about the so-called golden oldies, still remain and have a place, particularly when glycemic control is the main target. Thank you.
Dr. Sanjay, sir? Yeah.
Thank you very much, Dr. Madhu. I think it was a good overview of what our older drugs are, and as you showed all the data, they still stand so relevant today, despite so much of data coming in with all the new molecules. So it was a good overview, of the older molecules, and we still have strong data from them. May I request you to come back for the Q&A session at the end of it all, just a brief Q&A session. We'll let you know once the Q&A session starts. So we'll just have a few questions at that time. May I introduce our next speaker, Dr. R.K. Sahai. And Dr. Rakesh actually needs no introduction. He's been the immediate past president of the RSSGI. He's the president of SAFES. He's also the president of DIPSI, and he's been president of the Endocrine Society of India. He's been the section editor of Tropical Endocrinology, and he's been the associate editor of the IGDDC. He's got numerous awards to his credit and almost 200 publications. It gives me great pleasure to introduce him, and he'll be talking to us today on the overlooked organ, optimizing liver health and diabetes management. So over to you, Rakesh, for your lecture. Thank you so much.
So thank you, Dr. Sanjay, for the kind words of introduction. Thank you for inviting me to this program, and thanks to USV also for organizing this program. It's indeed it's my great pleasure to be on this forum with all the stalwarts from the field of diabetes and endocrinology here in India, to be here along with and presenting data presented at the ADA in the recent few weeks. So I'll just share my screen. So as Dr. Bansi had mentioned that we are realizing that the liver is a important organ which is often overlooked in the management of diabetes. We have been focusing on the cardiovascular outcomes of anti-diabetic drugs or cardiovascular outcomes in diabetes. We have been looking at renal outcomes, and we have not actually focused much on the liver. But now there is growing evidence that the liver has a significant impact on the outcomes, on both the cardiovascular outcomes and the various other outcomes in people with diabetes. So if you look at the global epidemiology of non-alcoholic fatty liver disease or non-alcoholic steatohepatitis among patients with type 2 diabetes, it is now we call it as MASLD now, and we see that there are about at least 436 million adults with type 2 diabetes, and 65% of them have MASLD. So as you can see, over the years, over the last few decades, we've been seeing an increase in the prevalence of MASLD. Clearly, it is on the rise. My screen is visible. Yeah. And if you look at the prevalence in people, I mean, if you look at the distribution of, as we know, MASLD progresses from initial phase of fatty infiltration to going on towards the development of MASH, and then going on towards more advanced fibrosis. So if you look at the distribution of these different stages of liver disease amongst patients with diabetes, we would see that majority of them are probably in the stage of MASLD and MASH, and then you see that a smaller percentage progress towards development of fibrosis and advanced fibrosis with cirrhosis, and going on even to hepatocellular carcinoma happens in a smaller number of individuals with diabetes, but nevertheless it is a significant number. Then if you look at MASLD, and as I was mentioning, the progression of MASLD goes through the initial phase of innoxious fat deposition, which we could say it is metabolism associated steatotic liver, and from there it goes on to development of inflammation, hepatitis, and then going on towards ballooning degeneration, which progresses towards fibrosis, and then this goes on to develop cirrhosis. So if we look at the associations of MASLD, we are clearly seeing that all the metabolic conditions are associated with significant degree of MASLD. If you look at obesity alone, 40% of individuals with obesity have this hypertension, again hypertriglyceridemia. So all individuals with metabolic syndrome tend to have MASLD as an important component of the metabolic syndrome that they have. And if you look at the awareness about this problem, even amongst the physicians and even amongst the healthcare providers, it is probably not as much as is required, because what we see is that even in the UK, 73% of patients were never referred to a liver clinic before they got admitted for cirrhosis. So obviously they have progressed from MASLD to MASH and then gone on to develop significant fibrosis and cirrhosis, and it is then that they have got referred to a liver clinic. So the recognition of this even amongst the healthcare providers is less, and the same scenario you see in Australia. 66% of patients were only diagnosed with NASLD and cirrhosis incidentally, and so cirrhosis patients are often unaware of the problem. Even in the US, you see that 69% were not aware of their earlier existence of this fatty liver or MASLD before they went on with the significant liver disease. And so this goes on to show that we need to be sort of more vigilant even in those with early stages of MASLD and early stages of fatty liver disease, to refer them, or rather, or to focus on the progression of this and prevent the progression of this condition towards more significant cirrhosis and more significant liver disease. And so if you look at the prevalence of different stages, again, as you can see in an endocrine clinic, you would see 22% of patients had F2 fibrosis, and about 14% had F3 fibrosis. Similarly, so on and so forth, to show that this is something which is very often missed out in the early stages and then presents at more later stages. And so even amongst the MASLD patients, the presence of the alcohol use also has a impact on the progression of fibrosis, because we always speak of this condition as non-alcoholic fatty liver disease earlier. But even in this condition, alcohol intake, even the moderate degrees of alcohol intake, can have a significant impact on the progression of this problem. And we also have a term which is the EMET ALD, which is used to denote the coexistence of metabolism associated steatotic liver disease along with alcohol induced liver damage. So that's the terminology that is currently recommended for showing the impact of alcohol on the progression of the liver disease. So if you look at the presence of these metabolic syndrome components, we know that we have different components of the metabolic syndrome, and when they are present in clusters, I mean, if you have more than one component of the metabolic syndrome along with the MASLD, the outcomes are going to be more adverse as compared to those who have maybe one component of that, or as compared to somebody who has three or four components of the of metabolic syndrome. So if you look at the growing prevalence of the problem, we could foresee that by 2030 there'll be more than 40 million individuals living with advanced fibrosis or cirrhosis in countries like the US, Western Europe, China, and Japan. And so this is a significant increase in the problem of liver disease, and we need to address it at an earlier stage of MASLD and prevent the progression, because it is in those stages that progression can be prevented. And management of the metabolic risk factors or factors, the metabolic syndrome components has a significant impact on the progression of MASLD. And we could see the impact in terms of outcomes like the disability DALYs, and the amount of DALYs lost with the development of MASLD, and the progression of MASLD towards HCC and the need for liver transplants. As you can see, there's a growing burden of that, and today we could say that the largest cause for liver transplant is MASLD. And if you look at the nomenclature which has been used by the ADA today, there are clear-cut definitions that have been given. Steatotic liver disease is labeled as MASLD when there is steatosis along with, that is, more than 5% fat in the liver, along with one or more cardiometabolic risk factors, which could be in the form of pre-diabetes or diabetes, present obesity, dyslipidemia, and hypertension. So any of these factors in association with steatosis in the liver is MASLD. And MET-ALD is where MASLD is occurring in the setting of increased alcohol consumption in the range of 20 to 50 grams per day in women, and in the range of 30 to 60 grams per day in men. So even in the setting where the alcohol intake itself is not, large enough to cause the fat liver disease, but the metabolic syndrome, MASLD, is modulated by the alcohol intake, moderate alcohol intake in that setting. Then you have the alcoholic liver disease, alcohol-associated liver disease, where steatosis occurs in the setting of sustained increased alcohol consumption of more than 50 grams per day in women and more than 60 grams per day in men. And other causes of steatotic liver disease should not be forgotten, because they could also be be the positive factors in some scenarios where we are missing out these, and we may be focusing only on the metabolic components. But we should not forget to look for these in those individuals who do not have significant cardiometabolic risk factors. Their steatosis, even without excessive alcohol consumption, could be pointed towards other causes of other reasons for steatotic liver disease. So if you look at the management of algorithm for MASLD today, what we need to look at is that which are the groups with the highest risk of progression to further cirrhosis, because there's a bidirectional relationship between MASLD and diabetes, and you could say that diabetes increases the risk for progression of the liver disease, and MASLD itself has an impact on the progression of diabetes complications, particularly the cardiovascular disease associated with diabetes. And then even in pre-diabetics, there's a faster progression in those with MASLD with pre-diabetes, have a faster progression to diabetes as compared to those without MASLD. And obesity also has a significant impact. So looking at the FIB-4 score is very important in these high risk groups, that is those with diabetes, pre-diabetes, or those with obesity. We need to look at the FIB score. When the FIB score is more than 1.3, also rule out other causes of steatosis in these situations, as we just discussed. And if they have a FIB score which is it is less than 1.3, then they are at a lower risk of progression. With them, they have a lower risk of progression to future cirrhosis. They can be managed by the primary care providers, but repeat FIB-4 score every 1 to 2 years. Optimize the lifestyle and treatment of comorbidities. When the FIB score is more than 1.3, we need to be more. There's a higher risk of future cirrhosis. We need to have aggressive lifestyle changes, and look at the liver stiffness parameters by doing a scan, and then a fibroscan can help us in identifying those with increased liver fibrosis, and they need to be referred to a liver specialist for further management, while those without increase in the fibrosis can be managed with adequate control of their metabolic parameters and metabolic components, and this could play important role in prevention of CVD and also prevention of advanced liver problems. So if we look at the ADA algorithm for prevention of cirrhosis in patients with MASLD, as you said just now, we are saying that we need to look at all these individuals, have a look at, do the FIP score universally in our patients with diabetes, pre-diabetes, and obesity, and stratify them, stratify the risk, and manage them accordingly. Now, if you look at the treatment algorithm, which has been suggested, that is MASLD in patients with all of them require adoption of a healthy lifestyle. Weight loss is certainly useful in all those who need a weight loss, and optimal diabetes management is particularly important. Cardiovascular risk reduction has to be addressed, and there is need for and in those who require metabolic surgery, that may be recommended, because that again has a significant impact in reducing in causing significant improvement in the MASLD. Now, obesity pharmacotherapy today in those with MASLD with MASLD has a significant impact on preventing the progression, and we have data from with the use of semaglutide on the progression of liver histology. Also, there was improvement in liver histology on the average from F3 to F2 in the recent trials with semaglutide. So I think that has been one of the important studies which was presented recently, and I think this is something which needs to be carefully looked at. Then we have effective therapies available today. We have we need to look at those with low low liver risk, where the main cause of death is the cardiometabolic risk, cardiometabolic disorders and cancers. So here, the treatment of underlying obesity, type 2 diabetes, and cardiac risk is very important. For the mid levels, where there is major risks again from cardiometabolic outcomes, from adverse cardiometabolic outcomes, we are actually progressing towards more adverse liver outcomes in there as we go up the pyramid. And so the management has to be accordingly modified so as to address the liver outcomes in those who are in this very high risk category, where we are looking at adverse liver outcomes. Some of the studies that were one of the interesting study that was presented was regarding this new molecule, which is a THRB agonist, which is thyroid receptor agonist, which has impact on fibrosis reduction and also has shown good resolution of MASH and improvement in the LDL cholesterol level. So this is one of the therapies that has been shown to be effective, the resmetirom, which has been shown to be effective for regression of MASH and regression of the fibrosis with MASH. And then we have the data on the GLP-1 RAs along with the MASLD, as I've just spoken about the ESSENCE study, where we could clearly see the improvement in the steatohepatitis with the use of semaglutide, injectable once weekly semaglutide in the dose of 2.4 mg per week. And there was a resolution of steatohepatitis with no worsening of liver fibrosis, and improvement in the liver fibrosis also, which was significantly better than placebo. And the synergy trial, which is looking at the effects of tirzepatide was also presented in the phase 2b trial of tirzepatide use in MASLD was presented, and that has also shown resolution of MASH in a significantly increased number of patients with tirzepatide doses of 15 mg. Showed much better results as compared to placebo, 62.4% resolution of MASH as compared, and even with the doses of 5 milligrams, you could see resolution of MASH occurring in 43% of the patients. And fibrosis resolution was also noted in a significant number of patients. And you can see that more than 20% weight loss is needed for a significant resolution in MASH. So what we have seen in summary is that GLP-1 receptor agonists are potent agents that promote weight loss and can also improve both steatohepatitis and fibrosis, although they have not yet been shown to be beneficial in cirrhosis. GLP-1 anchored dual and triple agonists are promising classes of molecules with encouraging data from the phase 2 trials. And while weight loss independent effects may exist, a substantial portion of the effect of GLP-1 benefits which are seen in MASH are related to the weight loss. Now, coming to a little word about SGLT2 and MASH, looking at the data that was presented on SGLT2 inhibitors. The SGLT2 inhibitors have also shown favorable impact on the fat content in MASH, causing a resolution of fat content in MASH. The earlier studies have been with empagliflozin. We have got data with dapagliflozin also, and with cana also, in terms of resolution of MASH of fat content in the liver. Long-term effects of SGLT2 on the liver stiffness in type 2 diabetes was seen in these studies, where there was some improvement which was seen, as you can see in this slide, in terms of the liver stiffness progression and the liver related events also. So SGLT2 inhibitors also significantly reduce liver fat content independent of their effect on the glycemic levels. Only few studies have demonstrated improved liver histology in patients with MASLD. Long-term SGLT2 treatment is associated with improved liver outcomes, especially the hemodynamic outcomes. Multiple mechanisms contribute to the decrease in liver fat content by the SGLT2 inhibitors, because they are working through a little different mechanism, and the hemodynamic effects probably have a significant role to play. Then coming to pioglitazone, we just heard about pioglitazone from Dr. Madhu, and their impact on MASLD also has been quite impressive in some of the studies. This is, if you look at the clinical assessment of a common medication like pioglitazone, this is the network analysis, network meta-analysis showing a benefit with the use of pioglitazone in terms of the liver fat content. And so combination therapy has been the studies with combination therapy using metformin, hexaconazole, and pioglitazone versus stepwise conventional therapy has clearly shown the benefit in terms of the liver fat reduction with the use of this initial combination therapy, and liver fibroscan measurements were used to show the benefit in this study of triple therapy versus stepwise conventional therapy. This study was conducted by, Professor Defonso was leading this study, and so therefore we have this combination therapy which has shown the improvement. And as you can see, pioglitazone shows improvement in steatosis and necroinflammation in patients with MASH, and long-term studies have shown the safety of pioglitazone in with additional CV benefits. Newer PPAR gamma agonists are the ones which we are looking forward towards to see if they have these similar benefits, and whether they would tackle the few adverse effects of pioglitazone, particularly the effects on the bone health. Future studies will be important to define the benefits of combination therapy with pioglitazone. So with that, I'll conclude. Thank you all for the patient hearing. I'll
Thank
stop.
you very much. Thank you very much, Dr. Rakesh, and it's been a very enlightening lecture. I request you to join back again once all the deliberations over for a short Q&A. It gives me a great pleasure to introduce our president of the IRSSDI, Dr. Vijay Vishwanathan. I think he's done incredible amount of work in the field of diabetic kidney as well as diabetic foot. I think he was the president of D-Foot International and has numerous awards to his credit. He has got a MV Diabetes Center at Chennai, the center has been doing incredible amount of work and has almost about 200 plus articles to his credit in peer-reviewed journals. So I think nobody better than him to take the next topic. He's going to speak to us from dual to triple, the new era of diabetes treatment. So I think, we are transitioning to many areas that were discussed in the ADA 25. And this was one of the area which Bansi did speak about during the opening lecture, that we are now looking at double and triple agonist and even quadruple for that matter. But what is important is how strong is the evidence, and when are we going to see these molecules come in for commercial use, and are they going to be safe from the patient's perspective? How effective they are going to be. So over to you, Dr. Vijay, for your talk. I'm sure everybody will be keenly listening to it.
Thank you, Dr. Sanjay. It's a real pleasure to be here tonight. And I don't want to stand between you and Professor Shashank Joshi, who's going to talk on obesity, which is the hottest topic of the day. I
So
think.
let me tell you, Vijay, right now we've got 3,000 plus delegates on the platform. It's a great amount of delegates that are there. I just took the count. So almost 3,000 plus delegates are listening to you.
So my job is just the opposite of Dr. S.V. Madhu, to talk on the new kids in the block. And let me see if I can justify it. So I'd like to thank Dr. Amit Gupta and the entire USP team for this opportunity. And I'll try to finish in 10 minutes. Can you open the slide, Amit?
Yes, sir. Yes, sir. Sure.
I've not changed it.
Yes, sir. Can you see my slides, sir?
Yes, the slides are visible. Sure.
Just give me a minute. I'm coming out. So from dual to triple uh, therapy, which is the new era of diabetes treatment. Next slide, please. First of all, I would like to start with the belief study, and I want you to all believe that we have something coming up. Can we improve the quality of weight loss by augmenting fat mass loss? But while we lose the fat mass, the preserving the lean mass is very important. So this is what the belief study showed or was all about. It was comparing bimagrumab separately, semaglutide separately, and both together. Can I have the next slide? Yeah. So they used two doses of bimagrumab, which is a activin type 2 receptor antibody, and subcutaneous semaglutide in adult men and women with obesity or overweight. And Sema was used in a dose of 1.0, 1.0 to 2.4, and both the combinations also. Next slide. You can see that on the left-hand side, blue color, the bimagrumab, the semaglutide, and the combination. Now you see a body weight reduction when you combine the two drugs. Fantastic, minus 22%, which is unheard of. With semaglutide, even 2.4, get only 15.7% reduction. You get minus 22.1, which is a fantastic reduction. Waist circumference reduced. And you see, I would like to go on to adiponectin. My point doesn't work. Adiponectin changed dramatically in people who were on combination. Adiponectin higher levels protects you against type 2 diabetes. So you see bimagrumab plus bima 30 plus semaglutide helps to increase adiponectin and reduce the chances of type 2 diabetes. So you can very well, jolly well use it in pre-diabetes. So next slide, please. So the combination is if you combine bimagrumab with semaglutide therapy. It results in a significant fat mass, including visceral fat, while the lean mass is preserved. That's very important. You will not lose mass, lean mass, which is very important. And HSCRP decrease and adipotic increase was greater than seen with semaglutide alone. Next slide, please. Next kid in the block is finerenone, which is uh, studied in depth. When you come to stage 1 to 3, uh, the early stages of nephropathy, you have patients who have uh, very little choices, and we don't really care about the kidney. We care about the heart, but we don't bother much about the kidney. But here's a drug, finerenone, which you should use in 20 milligram doses, not in 10 milligram doses. And this study was done looking at HbA1c on regular follow-up, receiving double uh, ARB, ARB, finerenone, and optimized for BP. And the blood pressure control was maintained by beta blockers or by using calcium blockers. And the EGFR using both cystatin and creatinine was used, though we have shown in the Indian Journal of Nephrology that creatinine is as good as cystatin C. But in this study, they looked at both creatinine and cystatin C to estimate the EGFR. And they also looked at potassium and UACR. Next slide, please. And you can see that the left-hand side shows you the baseline characteristics. The right-hand side shows the 6-month changes. A question was asked yesterday in the Journal Club, how long does it take for changes to be seen? You can see that EGFR is, after 6 months, it is significantly uh, increased, and EGFR by cystatin also increased uh, if you use both the drug, if you use finerenone and ARBs. Potassium doesn't bother. You don't have to bother much about potassium increase. You don't need hospitalization due to potassium. And UACR reduces from 170 on average to 101. Next slide, please. So the conclusion is finerenone significantly reduced UACR in type 2 diabetes in the early stages of nephropathy. Patients already must be taking ARB, SGLT2. It's an add-on drug. Never take it as a drug for primary use. It is on top of SGLT2 inhibitors and ARB therapy that you should use finerenone. The therapy was well tolerated with no blood pressure effects, EGFR, potassium, or glycemic control over 6 months. Next study. Next slide, please. Dapagliflozin is known to improve the kidney function, but how exactly it is got many mechanisms in the kidney, but it reduces the insulin stimulated renal glucose uptake, which is a new point. Now they did the FTG uptake changes in type 2 diabetes after DAPA treatment, and they assessed the kidney for 4 years. And the SGLT2 inhibitors role in reducing insulin stimulated renal glucose uptake was estimated. Now, the DAPA heart study had shown, it was a single center, 4-week prospective double blind control study. It shown that EGFR more than 60 you can use DAPA and prevent a heart failure and prevent a decline in EGFR measured by creatinine. But here in this particular study, they've used FTG scan during hyperinsulinemic glycemic clamp and measurement of the FTG uptake before and after 4 weeks of SGLT2. Next slide, please. Next slide. The conclusion from this study was the renal SUV peak significantly reduced the SGLT2 group versus placebo, which is expected. But if you use long-term findings, 4 years, the stable eGFR is maintained, pre-treatment is 81, post-treatment is 76. So it is useful to use SGLT2 like DAPA, EMPA also has been shown, EMPA kidney study has shown. Both DAPA and EMPA, this study looked at DAPA in particular. DAPA side effects, short-term effects are they reduce FTG uptake, the SUV uptake during insulin-stimulated state, suggests that SGLT2 inhibition lowers tubular energy demand and glucose uptake. It supports renal protective mechanisms, and long-term benefits are confirmed by studying 4 years. Next slide, please. And lastly, I would like to touch upon two molecules which are good for the kidney, the empagliflozin and the linagliptin combination, which are both shown to be useful in kidney disease. And this was insights from the previous slide, 1062 clinicians. Next slide, please. So rationale, the type 2 diabetes management needs to address glycemic control, cardiovascular, and renal protection. And it was conducted across India, and 1062 clinicians were involved, and 18,000 man-years of experience was used in the study. Next slide. And what is the findings? The key findings are 65 rated combinations are significantly more effective than other SGLT2 DPP4 inhibitors for HbA1c control. So EMPA plus LINA is good for glycemic control. Its highest suitability, multiple treatment needs, cardiorenal protection, uncontrolled HbA1c was the scores given by each doctor, clinician. Over 50% preferred it for simplicity and durability, and 51 rated it extremely important for managing type 2 diabetes. So EMPA with linagliptin is a fantastic combination for the kidney because it improves not only the glycemic control, it provides cardiovascular renal protection, and it also looks after metabolic needs, high agreement scores across 1,000 physicians. And the conclusion was it's trusted, durable, and versatile. It is trusted, durable, and versatile. So EMPA with linagliptin is a good combination we should be using more and more. Next slide. Thank you for your attention. Thank you, Dr. Sanjay and Dr. Amit, for asking me to talk.
Thank you so much, Vijay. I think it's been a very nice talk outlining all the data related to the newer double and triple agonists. I think it's going to be the future, and it'll be very interesting to watch on the horizon that what's happening there. And maybe as they are introduced into the market, we'll have more first-hand experience on how to use them. But as of now, the data looks very promising, and maybe we'll have a couple of questions for you at the end of all the talks, and hope that you'll just stay back to answer some of these questions. It's now a very proud privilege to introduce a great friend, Professor Shashank Joshi. I think he needs really no introduction. He has been the past president of RSSDI. He's been the past president of the API. He's been the past president of Endocrine Society. He's the emeritus editor of JAPI. I think it's a journal that I think practically all of us read all the time. He's been the past dean of Indian College of Physicians. He's been also the past chair of IDF Southeast Asia and past India chapter of ACE. So numerous, accolades to his credit. The list can just continue. But today I'm going to request him to speak on a very important topic, and the hot burning topic is obesity. And if you look at all the entire crux of the meeting was how is obesity management moving along today with the new introduction of new drugs, the newer agents which are gel incretin based. And I'm sure Professor Shashank Joshi is going to give us a lot of new news during his highlights. So over to you, Shashank, to discuss about next generation therapies for type 2 diabetes and obesity. Thank you.
So, am I visible, audible, and my slides are there?
Yes, sir. Yes.
Yes, it is.
So, first of all, Sanjay, thank you so much for your kind words of introduction. And we are all here because we are looking at highlights at the ADA Chicago meeting. And you must be reading in newspapers also the various cutting edge advances in diabetes and obesity. And I'm going to really talk on weight loss because that's the most hot topic today. And that's what everybody wants. So at the ADA, they had, I'm going to not do all the things, I'm just going to talk on 5 points. One is the pathway trial. Second is the stigma of weight and bias because people want to lose weight, but they have mental health issues related to weight. Then ultimately, we have now new therapies, and ADA launched its own obesity association for standards of care with overweight and obesity. Then two trials were having two-in-one medicines called CagriSema in the overweight and obesity space, Redefine 1 and 2, and one Chinese medicine for weight loss once a month. So now most of us know that there are these injections for weight loss which are once a week. But in ADGM, we saw this publication of once a week maratide trial, phase 2 study. And this is something which is also looking at very attractively. So let us look at pathway program. So what is this pathway trial? Pathway trial is basically a pragmatic approach for weight management that uses tools to build electronic medical records to overcome barriers and care. And these were basically explored in primary care, that is general practice. And clearly you can see in this study that weight loss did occur. And the weight loss was maximum in people in intervention group who received weight-related care, which you can see in the red line. And they lost around 3 kgs compared to those who did not get any care. So clearly you can see that at a population level, if you do an intervention and directed weight-related care, you can mitigate weight gain. So people don't gain weight. And maximum weight loss occurs in people who get care with intervention. And the best is more is the BMI, the more is the weight loss. So delivering weight-related care and breaking the stigma is very crucial. And I think it is important that everybody discusses weight as an important tenet in our healthcare management. And in India, it is more relevant because we have fat and weight both. Coming then to the second point of my talk is the weight stigma and weight bias. Because we know that when people gain weight, they go through a psychological trauma and barriers. And it is interpersonal, they feel discriminated, people can sham them, they get negative, confidence, they become non-inclusive and reclusive. They cannot fit in their clothes sometimes, that makes them very embarrassed. Sometimes some people make fun of them. And that leads to a big internal conflict in the human who's gaining weight in a denial situation. And then they keep on going through various treatment remedies. They get desperate. They like and dislike. They have very unfair assumptions. And then ultimately, they get into judgmental issues and they get a lot of stigma and depression. So that leads to stress. And that stress will lead to more binge eating, more caloric eating, maladaptation, disordered eating. Then the power of motivation goes away. And there are many people who do everything perfectly. And then that vicious cycle goes in. So remember that physiologically, when there is stress, cortisol, CRP, and A1C goes up, blood pressure goes up. But the negative health consequences lead to depression, anxiety, low self-esteem. And ultimately, we get caught into a vicious cycle of stress, weight gain, and stigma. So we need to change the environment. And today we are in an environment where we need to give a person-centered care for people living with obesity. We need to ensure that the waiting room chairs, examination tables, gowns, BP cuffs, high capacity scales are available. And we need to be flexible and accommodative for them. We need to be very communicative. We need to be very non-judgmental. We need to say person with obesity rather than obese persons. We need to engage them in shared decision making and not force our decisions on them. If somebody wants to lose weight, naturally we should allow them that. If they want to take a medication, we should allow them that. If they don't want, that's a different issue altogether. And we should have actionable steps. And today we have medicines to lose weight. So we can do education, we can enhance that education, we can have collaboration and communication. And now we have treatment options. And that was the standards of care which was launched at ADA, that we can actually make people lose weight. And weight management, if it's primary, will cause diabetes remission, will improve glucose, will reduce cardiovascular risk factors, will reduce sleep apnea, snoring, obesity-related cancers, reflux disease, even osteoarthritis. Only 5% weight loss will lower glucose and blood pressure. 5 to 10% of weight loss will prevent diabetes, reduce liver fat, cholesterol, and PCOD. That will also get reversed. Then, if you do 5 to 10 to 15% weight loss, you will reduce sleep apnea, snoring, GRD, reflux, osteoarthritis. And if you get more than 15% weight loss, you can get remission, decrease in mortality. And nowadays, it is not difficult to get 15% weight loss. And we have medical treatments which are available. They are grossly underutilized. But unfortunately, we are not educating people enough. So we need person-centered goals. We need to be realistic. We need to have the goals which are achievable, and we must ensure that the dose gets maxed out. Which medication to select? Yes, you can give either GLP-1 or GIP-GLP-1 injection, or oral agents are also available. We need to give them anti-complication drugs. The ABCDE of care doesn't go in A for A1C, B for blood pressure, C for cholesterol, D for diet, E for exercise. We need to get them nutritional chances based on their person. See, every human has a different choice of food. So we should modulate that food. So I have very simple philosophy: eat less, eat on time, walk more, and then counseling is the key. These were the two other big trials, and I'm just focusing on three trials today. One is, of course, the Redefine 1, then Redefine 2, and they were basically with semaglutide and carnitine, targeting appetite regulation and glucose control. And this was in Redefine 1 was 3,400 adults without diabetes, with at least one weight-related condition, and Redefine 2 was in diabetic space. And both these trials had, one of them had a non-diabetic population, other one had a diabetic population, and both of them lost around 20% of weight. Of course, with diabetes, the weight loss was less. So that is very, very clear. And when the adherence went up, the weight loss in Redefine was 22.7%, and Redefine 2, it was 15.7%. So adherence matters. People need to follow the advice. Safety was gastrointestinal. We all know that these agents can cause nausea, vomiting. They're usually transient, start low, go slow. And clearly, the final point was a phase 2 study, which is an agent which is once a month. Maritide, once a month agent. It actually mimics some hormones which are produced in the gut to tamp down the appetite and regulate blood sugar. And in this case, this was a randomized trial, and you could clearly see that up to 20% weight loss was seen, and 17% weight loss was seen in people with obesity and type 2 diabetes respectively. And most people lost more than 15% of weight. So we have an agent which is now once a month, which can cause weight loss and glucose control. So I thought in a very brief and quick way to share with you some insights on obesity. And I'm sure what you have listened and learned, you will try to apply it in practice. ADA had many presentations in obesity space. I just thought that I would cover up a couple of these key points with the brevity of time, and that we are running so late. I thought I just wanted to crisply analyze the same. Thank you so much.
Thank you so much, Shashank, for this excellent deliberation. And I think you brought, a lot of important points related to obesity management. If you had a crystal ball, Shashank, what do you think would be the final? Do you think it'll replace surgery? It'll go in conjunction with surgery? Will the indications for surgery get narrowed down? will the pharmacotherapy override all other forms of therapy? What is your crystal ball looking like?
My one single point take is BMI below 50, it will replace surgery totally. BMI above 50, which is morbid obesity, still surgery may be required. Between 40 to 50, there will be a fight between surgeons and physicians. Below 40, it's going to be pharmacotherapy. I'm very clear about it. And I think it is a remission drug. It's a disease modifying drug. So these drugs are here to stay. More and more drugs are coming in this space. So I think in the next 5 to 10 years, you will clearly see these drugs replacing a large proportion. 80% of surgeries are done between the BMIs of 35 and 50. And that proportion will shrink by 80%. Above 50 BMI, morbid obesity will still need bariatrics. Endoscopic procedures will fight with the medications, and medications will get better with lesser side effects and easier to take. And the side effects will be easier to handle. But this will
Thank you.
completely change.
And now with, of course, muscle sparing effects that you've got, this with our sort of, hesitation to have drastic weight loss with the fear that, are we going to lose muscle mass also is now getting taken care of. So I think these drugs are looking exciting. Let's see how the long-term trials look like. And I'm sure it has promising results. Now I'm going to go over to Rakesh and ask him that despite growing evidence, mast cell remains underdiagnosed until cirrhosis decompensation occurs. In your opinion, what systemic changes beyond clinical guidelines are urgently needed to integrate mast cell screening into routine diabetes practice, especially in resource-limited setting?
I think this is very important because we have seen, I mean, we have data showing that, muscle gets overlooked. Even if it is picked up, it is many times overlooked and not taken care of during the initial phases, and many of them progress to chronic liver disease and more advanced liver failure and the HCC also. So I think this is something which needs to be addressed right from the beginning, and the FIB score actually is a very useful score because you could do it without requiring any tests which are out of the way. I mean, these are simple tests which can help us in picking up those individuals who are at risk of progression and identifying that. So I think that is one message that everybody should go through, and it will help us in picking up individuals with mast cell who are likely to progress. We are able to pick them up earlier.
Thank you, sir. Thank you, Rakesh. And I'll go over to Dr. Vijay. The belief study highlights the potential to preserve lean mass while losing fat. Do you believe that future guidelines should focus not just on weight reduction, but on improving the quality of weight loss? So, how feasible is it to personalize this approach on routine diabetes care in India?
So, Sanjay, sarcopenia is a big problem among Indians, especially sarcopenia, which gets worsened with drugs like the weight loss drugs. So, people are concerned. People say they've lost weight when they're on SGLT2 inhibitors. So, they've lost lean body mass. So, this should not happen. And this new drug, which I showed you, when combined with semaglutide, produces fantastic benefits, and it preserves the in-body mass. What do you think, Dr. Sanjay?
I think so. See, we have all been talking about very large amounts of fat mass reduction. Now, in the ESD in Hamburg, they did have a lot of discussion that when you lose so much of fat, the muscle mass goes. So is it really a true muscle mass that really goes down, or is it a myosteatosis that reduces? And this discussion was also from the trial, the Surpass MRI trial. But now, of course, we know that there is a realistic loss of lean mass that tends to happen. And hopefully, with the new drug that you talked about, we should be able to have more confidence in using drugs that will cause large amounts of weight loss, along with fat mass, while preserving lean mass. So that's going to be a very encouraging thing to look at. So
Sanjay,
I
can I
think,
ask a question to Professor Shashank Joshi?
yes, Shashank, are you there?
Uh, Can we combine
Shashank,
metabolic?
Shashank, are you there? 1 minute. Let me see if Shashank is there.
Can we combine metabolic surgery with semaglutide or with tirzepatide? Can we combine it to have better effect?
Shashank, are you there?
No, I think he's not there.
So I think, to my mind, what I feel is the cutoff points are very much there in terms of where you need to do metabolic surgery and pharmacotherapy, and Shashank pointed that out to you. The key point that really remains is that post metabolic surgery, when patients lose a significant amount of weight regain always remains a challenge, for all of us. And people who, despite the fact that, they may follow lifestyle changes and all the recommendations post bariatric surgery, a large number of these people start getting a weight regain happening. The the argument is that just as you've got maintenance therapies for cancer chemotherapy and for anti-inflammatory therapies and all these things, why should we not have a GLP-1 analog that forms as the moment you find that there is an upswing in the weight that is happening, that why can't we introduce GLP-1 analogs at that point of time to keep the curve straight rather than allow it to go up, and then go back to the situation where the patient started out from. So a lot of people, including bariatric surgeons and obesity specialists, do believe that a combination of bariatric with GLP-1 is a good idea to keep long-term sustained weight benefit, but perhaps in sequence, not in parallel. So I think, we need to sort of evaluate patients. For me, what I do is, of course, post-bariatric surgery, I see the patient, where is the weight heading? And if I find that it's an upswing, we reintroduce the GLP-1 analog and keep it flat. But we give it for a short periods of time rather than as a continuum. I don't have a trial to show that, but the moment I find that the patient is steady and is following again sort of a very strict lifestyle modification, I may give him, sort of short periods of GLP-1 when I see that the curve is going upwards rather than keep him continuously on it. I don't know what Rakesh or Anuj would have experience in sort of using this. I think Shashank is back. So I think Shashank, Vijay had a question for you.
What the
That
Yeah, Vijay.
semaglutide with bariatric surgery, metabolic surgery?
You can combine, you can mix and match, and peri-bariatric surgery use semaglutide or Mounjaro. Both can be used.
So you get a sustained weight loss.
Yes, you can use it, and people are
but-
using it. In fact,
Particularly
all
people who are
the
regaining weight, as Sanjay was saying, that
Yeah.
maybe a couple of years after bariatric surgery, when they start regaining weight, then that again becomes a good option at that point of time.
No, but they are using it immediately also, Rakesh, after 3
Immediately
months or
also,
6
yeah.
months. And most of the bariatric surgeons are using it before surgery also, because many of the bariatric surgery patients are not fit. So in order to get them to get fitness, particularly people who have morbid obesity, I have had patients and they are not fit for surgery. They can't even move or get on the table. And you start them on the semaglutide or tirzepatide, and you can very clearly see that in fact we have been using oral semaglutide now for last 2.5 years, and we are routinely using it pre-bariatric surgery and post-bariatric surgery.
Okay, Anuj, can I ask you a question? And I'll try and keep this as the last question because we run out of time. Given on the relevance of sulfonylureas today, given the strong efficacy and low cost, sulfonylureas remain widely used. However, with the increasing emphasis on cardiorenal benefits, do you think that SUs fit into long-term treatment algorithm of type 2 diabetes in India? And can they still be a reliable choice in high-risk, high-CV risk patients? So what's your take? I mean, you've got now, all algorithms that are pushing SUs down, but in India, we still use it high, despite no convincing evidence of cardiovascular benefits. So where do you think the future is in India? Anuj, can you hear me?
Yes. Okay. I thought initially I thought that this question is for Amit.
No, no.
No, it's okay. Thank you. It's really very nice question in Indian perspective. we all understand for India we cannot remove sulfonylurea, but sulfonylurea is the medication which really does not address the pathophysiological basis of the diabetes, except it is just giving a boost to the insulin release from the beta cells of the pancreas. In the current scenario, when a lot of patients are going towards the cardio-kidney metabolism regulation, sulfonylurea's role is limited only to reduce the glucose level. Wherever we are finding, because all these medication, whatever available with the SGLT2 inhibitor, may it be the GLP-1 receptor agonist or DPP-4 inhibitors, they all are the fixed dose medication, which are not having a scope of much up titration or down titration, except little bit. In GLP-1 RA, we can think that. Sulfonylurea gives a additional value for lowering of the glucose wherever we are failing in achieving the glycemic target. So I don't think its value would be reduced, its use would be reduced in the coming days in India. It will continue remaining its place, it will continue going with its existing place, but its role in the cardio kidney metabolism is obviously limited. Its role is simply to help us in reducing the glycemic level, touching the glycemic target up to the appropriate or optimum level.
Yeah. Thank you very much, Anuj. And I would really like to thank all the speakers today who've done a really great job in bringing so much of new information from the ADA.
Question from the Karimnagar, which is close to Hyderabad. Dekonda,
Okay.
Tirupati
Okay.
Road, Dekonda. Is resveratrol
Yes.
available?
Yeah. Is resveratrol available in India and what is the price? So as far as I know, Rakesh, can you answer that question?
I think resveratrol is not yet available in India. We are
It
not.
is launched, Rakesh, it is launched by one Indian company.
Oh, is it?
Yeah, some 400 rupees or something per tablet.
Oh, is it? Okay.
80 or 400 rupees, I don't know, but it has been launched day before yesterday.
Oh,
I
okay.
saw a packet on somewhere, and a lot of patients are asking me also, Indian company, Andas or some company, I've never heard the name.
Yeah, okay.
But we are not sure.
So that's
news.
Yeah, that's news to me.
Thank you. Thank you so much. And really appreciate all of you spending your time and giving such valuable thoughts. And I'll pass now the platform back to Dr. Amit Gupta for his concluding remarks. And I would like to thank every speaker for sparing time and being over here to share their ideas. Thank you very much.
Yeah, thank you very much, sir. So on behalf of Team USV, I extend our heartfelt gratitude to each one of you for joining us for today's ADA 2025 live webinar in such a short notice. And I sincere thank you to all the stalwart of Indian diabetology for sharing their expertise and elevating today's discussion. I would like to appreciate and thank Dr. Banshi sir for his warm and inspiring opening remark, Dr. Anuj Maheshwari sir for setting the tone with the key takeaway from ADA 2025, Dr. S.V. Madhu sir for his in-depth perspective on sulfonylurea and combination therapies, and Dr. R.K. Shah sir for highlighting the critical role of liver health in diabetes care. Also, I would like to appreciate and thank Dr. Vijay sir for his expertise view on transition from dual to triple therapies, and also appreciate to Professor Shashank Joshi sir for unveiling the promise of next generation treatment in T2DM and obesity care. And a special note of appreciation and thanks to Dr. Sanjay Agarwal sir for steering the panel in such a clarity and in-depth. Thank you very much, and wishing you all pleasant evening ahead. Thank you very much on behalf of.
Thank you also, Sachin and Shivan, for keeping the digital platform so, enjoyed being part of this program. Thank you very much.
Thank you for the kind words.
Thank
Thank
you.
you.
Thank you, sir. Thank you. Thank you, everyone.
Bye-bye.
Thank you. Bye-bye.